So I think the good news is that some of the things we've discussed already, because as you've noticed, there's been a change in program. So I was supposed to give a little background now and then talk about the case, but we'll see where we get to. Thank you very much, Salvatore. So the question is, first of all, what is protective ventilation? We talked a little bit. And then the question of driving pressure, so whether there is a limit or a target. And then we'll talk a little bit about mechanical power. That is the final solution. As you've seen today, even before the final solution, what you've seen today or before lunch, essentially we've been struggling, haven't we, between these two options. Either we standardize and we go on RCT and population-based guidelines, which is obviously very practical, or we try and individualize, which is obviously much more difficult. But in a way, we could standardize the way we individualize mechanical ventilation. So the question is, first of all, tidal volume. Now, we always think about this study here, ADSNet, 6 versus 12, great reduction in mortality, but all the others, where they tested 7 versus 10, 7 versus 11, 6 versus 10, they've never shown any difference in outcome. And I'll show you later on at the end of the day with the new ARDS guidelines, actually you can see the forest plot that shows no outcome there. And the reality comes with this one, this idea that essentially if you give the same tidal volume to two different patients with different consolidation and different recruitability will be differently protected. And this is, I like this slide, and there's a video that Penny and Nada gave me, so I like to use it. And essentially what you see that when your baby lung or the small ventilatable lung is more or less small, the tidal volume will distribute in a different way, and so you can get the same tidal volume being protective or non-protective. And this was actually, back then, in 2000, was already there, this concept. Look, so this is the quartile of static compliance, and you can see the difference between low tidal volume and traditional tidal volume, which is quite marked if the compliance is low, but there is no difference if the compliance is larger, indicating that there is an interaction between mechanics of the patient or the respiratory system and tidal volume that is applied. And if you like interaction, this is even more marked, because basically this is a group of patients who didn't go into the ARMA trial, and essentially they were ventilated either from going from lower to higher tidal volume or from higher to lower tidal volume. And what you can see that depending on the pulmonary compliance or respiratory system compliance, patients had low pulmonary compliance. If they received a higher tidal volume, they had higher mortality. But equally, if the compliance was high and patients had a low tidal volume, the mortality was high. So you can see a really interesting interaction. That makes sense, because if you give the same tidal volume to different lung volumes, you've got a very different level of strain. So the idea is this, that if you think that lung volume is essentially related in some way to compliance, so higher compliance, here, means higher FRC. If you give the same tidal volume to everybody, regardless, you might find that some patients, particularly the ones with a near normal lung compliance, they might be hypoventilated, and some other patients might be excessively strained. And by doing mils per kilo of ideal body weight, we will never know. So that's one for sure. When we try and scale the tidal volume to predicted body weight, that doesn't seem to work. So the much better question, it would be to scale the tidal volume to the lung size. But we have a problem, because to scale the tidal volume to lung size, we need to know the FRC. Question is, how many people in this room measure the FRC? Not all at once. Okay, so if my calculation is right, nobody. And I think what we can see is that this is very difficult. There's only one ventilator that can measure FRC, and even that with some issues. But we can use some physiological derivation. We know that FRC and compliance are in a sort of way related. So in a way, instead of doing strain, which is tidal volume divided by FRC, given this relationship between compliance and FRC, we can do that the strain is similar to tidal volume divided by compliance, okay? So if you follow this a little bit more, we also know that compliance is tidal volume divided by plateau pressure minus PEEP. So if you do some high-level advanced mathematics and you remove the tidal volume from the numerator and denominator, what you're left with is that the strain is proportional to the plateau pressure minus PEEP, which is essentially the driving pressure. So the driving pressure will tell us at the bedside the idea of strain. So the higher the driving pressure, the higher is the strain. So the higher is the tidal volume that is related to the lung volume available. And I've showed you today this little case here, so I'm not going to go any more into detail, just the idea that to know precisely the driving pressure, to be absolutely certain what the real driving pressure to that particular respiratory system is, we should measure the airway opening pressure. So do you remember this study? This is got some couple of slides from Professor Gattinoni, who's been sort of talking about this and developing a lot of the mechanical power issues I will describe in a second. I don't know whether you remember, but this was one of the first studies saying that PEEP, famous study, that was 1974. I can see some faces. Basically saying that PEEP is protective. Okay, so what does that mean? So that was a lung ventilated with 14/0 and was basically intact. Then this one was 45/0 and was completely destroyed. You see hemorrhagic lung, very heavy lung, much bigger lung. And when to this 45 you add PEEP, actually the lung is protected. So the idea was, if you add PEEP, protect the lung. But at that time, this derivation here wasn't quite clear. That you can look at this in terms of driving pressure. So here's a driving pressure of 14. Here is a driving pressure of 35. Here is a driving pressure of 45. And as I said, I got this slide from Professor Gattinoni, who basically calculated the ventilation of this particular rat lung using the idea of mechanical power. And you can see here 45/0 with a different respiratory rate. You can see that as you go down on the driving pressure, or let's say go up from 14, 20, 30, 35, 45, you've got no damage, perivascular edema and alveolar edema, so with increasing level of driving pressure regardless of the PEEP. This is quite interesting because 14 is quite a magic number, isn't it? We'll see later on. There is no magic number, but as far as we are concerned, it can be an interesting number to remember. So if you think about this 14 now, we've got an idea that with increasing driving pressure, we've got increasing mechanical power, and we've got more and more lung injury. So if you analyze patients who received low tidal volume ventilation versus high tidal volume ventilation, you can see here that as you maintain the plateau pressure the same, and you reduce the tidal volume per predicted body weight, so the classical 6 mils per kilo, or 8 or 10 or whatever, you can see that the relative risk of mortality doesn't really change. So it looks like that if you look at tidal volume per se, it's not really an indication of lung strain. When you scale it to the tidal volume divided by the compliance that we said being driving pressure, now you start seeing a signal that as the driving pressure goes down, also your mortality goes down for the same plateau pressure. And I'm going to show you this one here. Again, you divide patients into high driving pressure and low driving pressure. Sorry, the other way around. High driving pressure and low driving pressure. Huge separation in outcome. Plateau, no signal. Volume, tidal volume, no signal. I find this quite interesting. So this was a reanalysis of the lung safe trial that you know is an international observational study, where they divided patients into, forget about the letter, but essentially low compliance, intermediate compliance, and high compliance. Now, if you look at the way these patients were ventilated, this one with high compliance was ventilated with 8.5 mils per kilo of predicted body weight. You would say this is really high tidal volume. You would rather have someone ventilated with 7.5 mils per kilo of predicted body weight. But when you take compliance into consideration, these patients had a driving pressure of 7.6, and this patient had a driving pressure of 17.3. So you can see now that looking at tidal volume, just tidal volume, they don't give you the full story unless you realize where the tidal volume is going, particularly in terms of compliance. And the way to do that is driving pressure. I've told you about this. I'm not going to say that again. And also the fact that I'm going to show you very briefly that when you look at survival, even at 3 years, patients who are ventilated with low driving pressure or low driving pressure had a difference in mortality. But you can see patients who had ventilated high or low tidal volume, no real difference. So again, the idea of thinking about mechanics and thinking about the individual patient. But clearly, if you take a population level, driving pressure has been shown to be associated with outcome, even in patients who are ventilated postoperatively. So we don't need to have lung injury, but just the idea of ventilation is quite important. And if you increase the driving pressure, even in normal patients, then we'll have more of an outcome. And this is quite interesting. So again, take all patients, quite a lot of patients who were randomized in the low versus high tidal volume. You divide them in quintiles of driving pressure, so 8.5, 12, 14, 17, 24 of driving pressure. You do the same for respiratory rate, and you do the same for tidal volume. Now, what you can see, the tidal volume, there is no real signal, and you can look at the p-value. In other words, you can be on the low tidal volume quintile or the high tidal volume quintile, and essentially outcome is similar. However, if you are in a low quintile of driving pressure or high quintile of driving pressure, the standardized mortality ratio is not the same. And you can see there, 1 is around 14, above 14, 15, which is very similar to the animal studies, which is quite interesting. But also, what Salvatore was saying earlier on with these animal studies, you can see also the respiratory rate is quite important. And it makes sense. If driving pressure of 20 is injurious once per minute, if you do it 35 times per minute, it makes more sense that it's more injurious. So now the question we've got, driving pressure and respiratory rate. And do you remember earlier on we were saying, how do you decide whether to increase driving pressure and decrease the rate, or vice versa? Now, this is an interesting idea, is the idea that this is a population level, and this is one step forward towards mechanical power, that essentially you can take patients, let's say, patient with low compliance. Here you've got driving pressure of 21. I know this is extreme cases, and a respiratory rate of 45. You said I'll never go above 30. They did. It's not great, but just this for mathematical purposes. So now if you combine these two and you multiply the driving pressure by 4 and you add the respiratory rate, I've done that for you and I've done it twice, so I think he's right, is 129. Now, if you want to see whether it's best to give more respiratory rate or more tidal volume, let's say that now your driving pressure is increased, so you give more tidal volume and less rate. You do the same operation again, and you can see that this number is 138. The higher the number, the higher the odds ratio of death. So in this particular patients with low compliance, actually it's best to be on a higher respiratory rate and a low driving pressure than the other way around. Whereas in patients with higher compliance, this might be very different. So you can't really tell at the bedside, and so some ideas of calculation when you do the changes at the bedside might give you an indication whether you are going up on the odds ratio of death or down on the odds ratio of death. The problem, this is great when you've got a patient who is paralyzed and on propofol, fentanyl, rocuronium, or whatever else. The question is, how do we know the driving pressure of patients who are spontaneously breathing or in assisted ventilation? Well, this is an interesting idea. So let's imagine that you've got a patient in assisted ventilation. You've got a pressure, the airway pressure that you can see because you can read it on the ventilator. And then there is the negative inspiratory force that the patient is generating that we can't see. And the question is, how do we make this visible? Because this plus this is the total driving pressure of the respiratory system. So one of the idea is that you can do a end inspiratory occlusion maneuver. So you ask the patient, we're going to do a maneuver, you need to relax, try and relax. When we do that maneuver, there will be a plateau pressure. Now, the interesting thing about this plateau pressure is that during a plateau pressure, there is a relaxation of the muscles, and this pressure, which was first was negative, is going to move and become positive and will become visible. I'm sorry about the colors, looks better over there. But essentially, you've got now a plateau pressure that is higher than the peak pressure, yeah? And this difference, the difference between plateau pressure during spontaneous and the peak, which is basically your peak pressure before the plateau, is called the pressure muscle index. I'll show you in a second. Don't be scared by the names. Essentially, this is what it looks like. So this is flow. You do an inspiratory hold, so there's flow 0. We know that the maneuver is great. And then you've got, this is the peak airway pressure. Do a plateau, and the pressure rises during a plateau. So now, this one, the entire system, so the plateau pressure minus PEEP is the real driving pressure of the patient. So you can measure driving pressure even in patients who are spontaneously breathing, provided you do this maneuver. So moving to a mechanical power is essentially, I like this idea that you start with this horrible equation. So look away, look away. But essentially, this equation, deep breaths, will tell you that the pressure in the respiratory system depends on the volume times the elastance, the flow and the resistance, plus the PEEP. So this is a pressure. If to this pressure you add volume to each term, you obtain pressure times volume is work. And if you add the respiratory rate, work times the respiratory rate is power. And essentially you take all this idea, all these components, and you make one number, which is your mechanical power. Now, if you don't like horror movies, you just look away, because this is the derived. But essentially, when you look at this phenomenon here, it's basically the first component. And then you've got the resistance, the second component, and this is the third. You can work it out, but essentially to say that this is what it means. It takes everything into consideration, all the pressures, all the volumes, and the rate. Okay, so the idea that this is a final solution, and basically with one number, the idea we can decide where we are protecting or we are injuring. The question is there a magic number? I don't know. But if you interrogate some databases, you can see there appears to be a threshold of mechanical power above which the mortality rate is above 1. So, and here was between 17 and 19. And some other studies have done the same. Look at driving pressure, the one I've showed you before, and also mechanical power above and below 20. The question is 17, 18, 19, 20, I don't know. But the important thing is that you have one number that can capture all the elements of the mechanical ventilation. I'm just done a little exercise, just more for myself than for anybody else. This is the REST trial. You've all read the REST trial. So REST trial is essentially the idea that you've got moderate severe acute hypoxemic respiratory failure, and you randomize patients into very low tidal volume ventilation, so less than 3 mils with echo 2R for maximum 7 days, or just conventional, just low tidal volume. Now you can see from the half-empty thing there, it's severely underpowered, 412 over the projected 1,100. But look at this, no difference in mortality, okay? Actually fewer ventilator-free days in low tidal volume ventilation, more side effects, more intracranial hemorrhage. And you say, hold on, if 3 is good, 6 is good, 3 should be better. Why we've got this problem? The problem is, I went to the supplement and looked at day 3. Look at this. So patients have had 6 mils per kilo, okay? So this is the tidal volume, 6 mils per kilo, and had a respiratory rate of 23 on average. When patients received 5, okay, it was 5, but the respiratory rate went up to 28. Then 31 and 35. So when you take all the, you see, if you look at just tidal volume, say, great, isn't 3 great? But 3 now costs you 35 respiratory rate. So when you put it together as mechanical power, look, the difference between 5 and 6 is 16 in the control, which almost very similar, below 20, and 15 in the 5 mils per kilo, or 12 in the 4 mils per kilo. So the question is, if you've got a reduction in tidal volume, an increase in rate, and mechanical power doesn't change too much, would you expect to see any difference in mortality? I don't know. So in that case, the idea of mechanical power could be useful because take into consideration all the other things that you need to do to compensate for the very low tidal volume. PEEP. Well, one of the things we said earlier on, just basically you've got patients A, you give a lot of PEEP, you transform into this one. Is it a good thing or a bad thing? So the idea was that you've got increase your PEEP level, you look at the driving pressure. If the driving pressure remains the same, you say actually PEEP doesn't help, whereas if the driving pressure goes down, then PEEP does help. This is very sort of initial thought, but we said we disagree with that. We disagree with that because the theory is that you've got consolidation here, you've got collapse here, and you've got normal lung there. And if you increase your airway pressure, you can distinguish either you recruit, and in that particular sense, you've got lots of recruited lung and collapsed lung goes down, so the driving pressure will be lower because you've got more lung, and in this case, you've got higher driving pressure. But that's not the full story, because when we look at mechanical power, you can see one thing. If you take this mechanical power for pressure control ventilation, for example, you can see the element of PEEP is there. So let's give 2 examples. One example is patient with low PEEP, so 11, plateau is 25. We checked the low flow maneuver and there is no airway opening pressure. So this is the true driving pressure, is 25 minus 11 is 14. If you take a respiratory rate of 20 and half a liter of tidal volume, you basically make this calculation, which will give you a mechanical power of 24.5 joules per minute. Okay, now we've increased PEEP to 22, because we are big PEEP. Plateau pressure is only 30, so the driving pressure is halved. But when you put all the data inside, you can see that now the mechanical power is actually increased. So, okay, the idea that when we look at one parameter and we need to do a lot of other things to compensate, the total amount of energy might be higher, might be lower, or might be the same. In this particular case, it's certainly much higher. And I showed you this during the, case, so I'm not going to repeat again plateau pressure and the total strain there. And you see again increasing, and the mechanical power also increasing from 22 in this particular case to 25. That was that patient. The problem, you can say, I like PEEP anyway. So if we have two patients with the same mechanical power, would you go for a higher PEEP for the same power or lower PEEP for the same power? The answer is I don't know, but I can tell you something again from some of the studies that you all have done here. Basically, when you have mechanical power going from low to very high, what you can see, first of all, is that the lung edema increases. Every time you give a lot of PEEP, a lot of mechanical power, the edema will increase. And if you look at this one here, the PF ratio increases anyway. So this idea that if you look at blood gases, you're always better off with high mechanical power. But if you look at other things, particularly the fluid balance, obviously patients with high mechanical power and high PEEP might need more resuscitation, and that is a problem. And if you look at here, the lung weight increases and the wet to dry ratio increases. So one of the ideas would be also to think about that the same mechanical power that you give to 3 different lungs might be different based on the size of the lung. So you've got a big lung, you give a certain amount of power divided by 1 liter, you get 21.1 millijoules per minute per milliliter. And you can see as the patient becomes more and more severe, the force that goes into the available lung increases. And actually there is some data showing that, and this is my last slide, that if you look at this one here, if you look at patients with mild disease, it doesn't matter what mechanical power you give within reason, mortality doesn't really change. But when you're going to severe, then obviously the amount of energy per predicted body weight also will progressively increase. So that's just an idea that you give. You were saying earlier on, what is the pressure? Is the pressure over an area? If you've got a large area, the same pressure would be less injurious than the same force on a smaller area. So this is my conclusion, just to say that driving pressure is a good measure of scaling of tidal volume, but is not, it helps with tidal volume setting, but not with PEEP. So I wouldn't recommend using the PEEP level that give you the smallest driving pressure. Mechanical power is the total energy, but actually we don't know how we use it and what is the threshold, either total or scaled mechanical power. So this was a quick run through of driving pressure, mechanical power. Any insults here? Thank you very much.